Introduction to Interpretation of Prostate MRI at UCLA. Practical tips for urologists and urology residents. Prostate multiparametric MRI is increasingly used in the diagnosis and management of prostate cancer. Interpretation of prostate MRI, however, can be challenging for a number of reasons. There are numerous sequences within these studies with different characteristics and with different uses. There is often institution-specific terminology that can make identification of the sequences of interest difficult. And the findings on these studies can often be somewhat subtle, and the interpretation of prostate MRI requires experience and practice. So the purpose of this talk is really to serve as an introduction to prostate MRI for clinicians and particularly urologists. It will help to introduce the correct sequences for interpretation, and we will focus on the UCLA specific sequence names that are of interest. We'll talk a little bit about which sequences are good for what. We'll review some examples and some cases. I'd like to be clear that the PIRADS system, which many of us have become very accustomed to, is beyond the scope of this talk. We will not attempt to go into the PIRADS grading system, as that is a significant topic unto itself and is beyond the scope of this very introductory level talk. So we'll start with some basic MRI terminology. So when we're talking about magnetic resonance, brightness on an MR is referred to as something being hyper intense. So intensity refers to the brightness or the darkness of an image. Bright areas are termed hyperintense. Dark areas are termed hypointense. And ROI stands for regions of interest, and those are areas within the image and within the prostate for which we are suspicious that there may be a malignancy. Prostate MRIs are typically and most commonly viewed in the axial plane, although coronal and sagittal planes can be useful for certain things. Viewing in the sagittal plane can be useful for interpretation of the shape of the gland and to determine whether or not there is a median lobe, and can also help determine the overall shape of the prostate gland. So there are several key sequences that are used when interpreting a prostate MRI. The first are the T2 sequences, and these sequences are essentially the best anatomic view of the prostate. They provide crisp anatomic delineation. They are best for interpreting the overall shape, size of the prostate and the different zones of the prostate, and they are very useful for identifying malignancies in the peripheral zone of the prostate. Then there are two additional sequences known as diffusion-weighted imaging and apparent diffusion coefficient. And these are very important sequences in prostate MRI. They provide relatively poor anatomic delineation, so you do not get a good look at the shape and margins of the prostate gland on these sequences, but they are very useful for identifying malignancy, particularly for identifying cancers in the transition zone, which can often be difficult to see on the T2 sequences. And they are also very important for confirming malignancies in the peripheral zone. The final sequence is known as dynamic contrast enhancement. And this is actually a T1 sequence that is taken before, during, and after contrast administration. So contrast administration is part and parcel of a multiparametric MRI for prostate cancer, and dynamic contrast enhancement evaluates the degree of contrast enhancement of a particular region of interest and it allows for evaluation of angiogenesis within this region of interest. Radiologists will actually make quantitative measures of the rate of contrast enhancement and washout, and that can help determine whether or not the area that they're looking at could be a malignancy. So let's get into a little bit more detail about these particular sequences. We'll talk about the T2 weighted images. So again, these are crisp anatomic looks at the prostate. They're good for looking at anatomy, and they're good for looking at cancer when it's in the peripheral zone. And at UCLA, these two sequences there are actually two different T2 sequences that can be useful to look at. The first one, you'll see the name here. It has this, it starts with T2 at the beginning and it ends with this 320 here. So that can help you. I always look for the T2 and the 320 to identify that sequence. And then the next T2 sequence that can be useful is this one. It also starts with T2 and it ends with OBL underscore prostate, or axial oblique prostate. Those are the two T2 sequences that you want to look at when you're looking at prostate MRI at UCLA. Here's an example of what they will look like in the sequence navigator in our PACS system on the left. So this is the one that ends with 320 here, and this is the one that ends with this OBL underscore prostate. Those are the two T2 sequences that are of interest in prostate MR at UCLA. That's what the names look like. So let's look at an example of a T2 weighted image of the prostate. This here is one of the T2 320 sequences, and we're looking in the axial plane here. You can see here the rectum is here, the prostate gland is here, and the prostate involves the entire this entire zone here that you're seeing that is hyper intense here. That is the peripheral zone, and this kind of heterogeneous mottled area in the center, that is the transition zone of the prostate, and the urethra will be right here. And so that is a fairly normal looking peripheral zone. You can see it's fairly homogeneous and it has a smooth hyperintense appearance, and that is a normal looking peripheral zone. And this is a normal appearing transition zone with relatively minor amount of BPH. Here's another example of a T2 weighted image. Again, it's this 320 sequence. We see here again, the peripheral zone is this sort of a curvilinear shell-shaped outside area of the prostate. It's relatively homogeneous. It's relatively hyperintense. And then the center here, you see the transition zone with this kind of heterogeneous mottled appearance, and that's fairly typical for BPH. So both of these are examples of that 320 T2 sequence where we see a relatively normal appearing peripheral zone, at least on these particular cuts, and some mild to moderate BPH changes in the transition zone. So again, these are some examples. So these are some normal findings. So again, these are the 320 T2 sequences. And what I wanted to demonstrate here is some examples of BPH. So this is that first prostate we looked at, and you can see here this BPH area. It looks sort of nodular, it's heterogeneous, it's kind of bubbly. There is some areas of hyperintensity and hypointensity. Here's another example of more substantial BPH. So this entire area is enlarged with BPH, and you can see some of these BPH nodules. One thing to keep in mind, these BPH nodules are very well circumscribed. So a very large nodule like this that's hyperintense but very well circumscribed, that is the typical appearance of BPH. Well circumscribed nodules can be heterogeneous. There can be areas of both hyper and hypointensity. So here is another T2 image. I've zoomed in on it so you're not seeing the whole thing, but this is one of these T2 320 sequences. And here again, we're looking at the peripheral zone, which will be on the outside of the prostate here. And what we're seeing here is rather than having that very smooth, hyper-intense appearance, there are some areas of hypo-intensity. And This is an area that was biopsy proven to be cancerous. By the way, all of these cases are actual cases of patients at UCLA. And you can see here this area of hypointensity in the peripheral zone. It's relatively poorly demarcated. There's sort of a border appearance here, but on the other side of this lesion, you don't see a strong border. And it has kind of an abnormal shape. It has a little bit of a smudgy appearance. So malignancies in the peripheral zone will not be well demarcated. They'll be poorly demarcated. They'll be hypointense or dark. They can look smudgy, or I've also heard it described that they almost look like a thumbprint on the peripheral zone. So this is an area of biopsy-proven cancer in this patient's that ended up being a high-grade cancer in this patient's peripheral zone. Here's another example. So this is an MRI that we've not looked at. Again, it's a T2 weighted sequence. And here we don't see such a well-delineated peripheral zone on this MR. You can see here the anterior, the transition zones here. We don't see quite as not as well delineated peripheral zone here. But you can see on the left side of the peripheral zone, there's a hypointensity. So that's what we're looking for in the peripheral zone for cancer, hypointense. It looks, the borders are relatively indistinct. It's not well demarcated. It's poorly demarcated. And it has kind of a smudgy appearance. And this also was ultimately found to be a biopsy-proven clinically significant prostate cancer. So one of the things that can be tricky about prostate MRI is that we've shown some examples of dark things in the peripheral zone or hypointense things in the peripheral zone that are malignant, but there can be things in the peripheral zone that are hypointense or dark that are not cancer. So that's the title of this slide, is not all hypointense things in the peripheral zone are cancer. Here's a couple examples of that. So this again is the peripheral zone that we see wrapping around here. It's hyperintense, as you would expect, but in the middle, there's this area of kind of poorly demarcated hypointensity. And you might think, well, poorly demarcated, hypointense in the peripheral zone, that should be a prostate cancer. But in fact, that is not the case. So the central zone of the prostate, which is in the center of the prostate, sort of adjacent to the peripheral zone, is also hypointense. And so one tip off here is that this darkness is in the expected area of the central zone. That's number one. Number two, if you were to scroll up and down, you would see that this area actually communicates with the seminal vesicles and the ejaculatory ducts. And the central zone is where the seminal vesicles, where the ejaculatory ducts run through the prostate. And so that is a tip-off that this may not be a prostate cancer. It may just be normal central zone. And we'll talk further about how you can confirm or refute that using the other sequences. But if you see something in the midline of the prostate here in the central zone that is somewhat symmetrical, you should be potentially thinking that it may not be a cancer. It may be just normal central zone. The other thing that we see quite often in the peripheral zone that is not a prostate cancer are signs of possible prostatitis. Prostatitis is a pretty common finding on prostate MRIs. Prostatitis looks different than prostate cancer because rather than having that kind of poorly demarcated, smudgy appearance, it often has this kind of striated appearance. So you can see that there's a stripe here, there's another stripe here, and there's another stripe here. Or they can be wedge-shaped. So this is another sign that this is probably not a prostate cancer. And again, we'll use our other sequences to confirm or refute that hypothesis. But when you see striated, wedge-shaped, or striped-shaped hypointensities in the peripheral zone, you have to be thinking that it may not be cancer, it may be a prostatitis. So let's move on to some of the other very important sequences here. We'll start with diffusion-weighted imaging. That's the next sequence. So what is diffusion-weighted imaging? The way that diffusion works is that it measures the ability of water molecules to diffuse throughout tissues. And the diffusion of these water molecules becomes more restricted when there is an increased degree of cellularity within the tissues. So cancers tend to have increased degrees of cellularity, and as a result, that results in a decreased ability of these water molecules to diffuse. So that's the basic kind of layman's description of the physics of how this works. Increased cellularity leads to increased tissue density, which leads to decreased level of diffusion. These images provide relatively poor anatomic delineation. It's oftentimes difficult almost to see where the prostate is on these images. Unlike the T2 sequences where cancers are hypointense, on diffusion-weighted imaging, cancer is hyperintense or bright. And in these sequences, it can also often require some degree of windowing to actually optimize your identification of the lesion. So you may need to sort of window the images in this sequence in order to identify areas of regions of interest. So at UCLA, the diffusion-weighted imaging has a very, very long name that I've described here. But one thing that you can look for is basically this BVAL, calc, BVAL, and DFC. So that's what I do when I'm looking at these images. I find the one that has this very long name here, and I find the one that says calc, BVAL, DFC. That is the diffusion-weighted image sequence that you're going to be interested in looking at. So let's look at some of these images. So again, in diffusion-weighted imaging, the anatomic discrimination is relatively poor. You can see here, you can sort of barely see the outline of the prostate gland here, and you certainly can't see this. It's hard to see the sort of different zonal anatomy. Cancer is bright, which is also known as hyperintense. Windowing can help highlight the lesions. And because of the poor anatomic discrimination, a lot of times it's helpful to look alongside your T2 weighted images. So you may recall, this is that example I showed before of this relatively large conspicuous lesion in the right side of the midgland of the peripheral zone here. This is that T2 320 sequence that lets you look at the prostate very well. And then these are the diffusion weighted images. So this is what it looked like before I windowed it. Now this lesion is very easy to see on the diffusion weighted imaging even without windowing, but sometimes it's not this easy to see. It's sometimes it'll be hard to see without windowing. This is before I windowed it. This is after I windowed it, so you can see, after windowing it's even more conspicuous. But again, sometimes it's good to look at these things next to each other. So I will often pull up the T2 and then I'll pull up the diffusion weight sequence and try to sort of match them up, and sometimes I have to window it to sort of see if there's something that I can identify. So let's move on to the next sequence, the ADC, or the apparent diffusion coefficient. How does this sequence work? Well, it's relatively similar to the DWI, or diffusion weighted sequence. It's measuring diffusion. ADC is actually a map of calculations of diffusion, and in practical use, it's really just kind of used to confirm the findings of the DWI sequence. So oftentimes, in order to know if there's really restricted diffusion or whether or not you can really confirm that there's restricted diffusion, you have to look at both the DWI and the ADC. So they kind of are a pair. Like DWI, the anatomic delineation is very poor. It's kind of hard to see the prostate gland sometimes. The regions of interest on ADC are hypointense or dark. So it's like the T2, you're looking for dark stuff. So at UCLA, again, the sequence has a very long, kind of confusing name. Sometimes it feels like it's hard to find it. But you want to look for this long name, and you basically want to look for ADC, and that's sort of what you'll do as you're scrolling through your sequences. So again, here's on that sequence navigator, here's what you'll see, and you'll see the ADC here, and that's your ADC sequence. So again, here are some examples. It's that same tumor we saw before here, and again, I like to often look at it alongside the T2 weighted image. So here's the 320 T2 here. And then here is the ADC map without windowing. And again, this is a very conspicuous lesion. You can see it dark here or hypointense on the ADC without windowing, but then this is with windowing. You can see it even better. So that is your ADC map. So let's go on to the final kind of sequence that is relevant, and those are the dynamic contrast enhancement images. And again, it's a little bit just sort of like a washout on CT. They're basically looking at the degree of enhancement during a contrast bolus, but before the bolus, during the bolus, and after the bolus. And tumors, cancers of the prostate, tend to display a pattern of early enhancement and rapid washout. And as a urologist and a clinician, you're not going to be able to sort of make these calculations, but they do provide them an enhancement curve on, sometimes at UCLA, you'll be able to actually look at these curves. If you're looking at an image from outside, you may not be able to actually look at the curves. But one of the cutoffs for enhancement is a 200% increase enhancement by 40 seconds. So I've got 3 examples here of what that looks like. So on the left side, I've put on all of these, I've put the red line at the 200% enhancement point. And then along the x-axis, you see here the time, the time of post-bolus. And on the left, you can see here, this particular region of interest reaches a 200% increase at looks like about 10 seconds. So that would be considered positive for early enhancement. This other tumor, you can see it reaches the 200% enhancement threshold at around 30 seconds. So that's also positive for early enhancement. And then here's another example of a region of interest where the region did not get to the 200% threshold until around 56 seconds. So that was considered negative for early enhancement. All of this data goes into the radiologist's interpretation of the PI-RADS grading of a lesion. And so because we're not really going to get into the details of that, it's a little bit less clinically useful for you as a clinician, just kind of looking at these images and getting a sense of what's going on your MRI. But I think it's worthwhile just understanding what this means and how they measure this. So you will not be measuring this yourself. This will be provided to you. So let's talk a little bit now about anterior tumors in the transition zone and the anterior fibromuscular stroma. So I wanted to go through the diffusion sequences before talking about this because they are very, very important for identifying anterior tumors. Anterior tumors can be very difficult to see because of the heterogeneous nature of BPH. So we went through those peripheral zone tumors, and typically you can see, that nice, smooth, hyper-intense white peripheral zone, and anything dark in there on T2, requires evaluation on the DWIs and the ADCs. The problem is in the anterior aspects of the prostate, in the fibromuscular stroma and in the transition zone, there's all this modeled BPH, and the T2 weighted sequences are very hard to use to find prostate cancer in there. So that's where the DWI and ADC sequences are helpful for identifying lesions in those areas. So let's look at a couple examples of that. So here's a patient. On the left, you see the 320, the T2 image, and you can see his peripheral zone here. It's relatively homogeneous. It's hyper-intense. There's not a lot of hypointensity. You see maybe this little strip of hypointensity there, but that is more consistent with some kind of inflammation or prostatitis. This patient has relatively significant BPH, so you can see all the BPH in here, and it's hypointense, and it's very difficult to see whether or not that's actually prostate cancer or what that might be. And then you see here an example of a very relatively conspicuous tumor in the anterior fibromuscular stroma. It's very hypointense there. This is a pretty obvious example of something that's abnormal. And then what you'll see here is on the DWI sequences, so this is DWI, and you can see here that area is corresponding to a hyperintense area on DWI, and then on your ADC map Here, you can see a very dark area of hypointensity here on the ADC map. So that would be consistent with a prostate cancer. There's some other findings here on DWI that would require, I think, a little bit of a closer look. They don't really have a strong correlate in the ADC map. And I think that degree of subtlety probably, at least when you're starting, would require the assistance of your radiology colleagues to tell you whether or not there was something else hidden within that transition zone area. But certainly this lesion here, very dark, very hypointense on T2, hyperintense on DWI, hypointense on ADC, very concerning for a possible prostate cancer. This ended up being graded as a PIRADS 5, and a biopsy of this showed relatively high volume Gleason 3+4 prostate cancer. So that's an example of a tumor in the anterior zone of the prostate that can sometimes, in this case, relatively easy to see, but these things can be difficult to see. So here's another interesting example. This was the same patient in whom we were showing these striated wedge-shaped stripes in the peripheral zone, and we said those are not really consistent with cancer because of their striated nature. The other interesting thing, so I said that, when you see these dark things in the peripheral zone, you need to confirm them on your ADC and DWI. So if you look on our DWI in that area of the prostate in the peripheral zone, we really don't see a hyperintensity there. So that, again, not consistent with prostate cancer. And on your ADC, you don't see a hyperintensity there. You don't see a hypointensity there, really. So again, not really consistent with the prostate cancer in the peripheral zone. But what we do see, if you come back, is in the transition zone, just anterior to the urethra, actually, in that little strip in there is the urethra, you do see a hypointense area there. It has a little bit of that kind of smudgy appearance. This one is a little bit well demarcated, but certainly there's something there that's hypointense on your T2. You go to your DWI here, there's a hyperintensity there, exactly corresponding to that same location. You go to your ADC map, it's a significant hypointensity there. And so that would be consistent with a prostate cancer. And that cancer is just anterior to the urethra, certainly not an area that would be biopsied on a traditional ultrasound-guided biopsy. And this patient, we biopsied all of his systematic peripheral zone ultrasound-guided cores were benign. And these targeted cores to just anterior to the urethra all showed Gleason 3+4 prostate cancer. So this is an interesting example. And again, potentially easy to miss this on your T2, but if you scroll through on the DWI, you clearly see something. On the ADC, you clearly see something. And so sometimes you go back and look at your T2 and say, oh yeah, boy, there's something there. Let's look at another example. So here is an example of, on the left side, we're looking at our T2 image here, and you can see the peripheral zone here in the posterior looks reasonably homogeneous, reasonably hyper-intense as you'd expect. Here's our transition zone, and the first thing that kind of jumps out is, wow, there's this sort of structure here, but again, consistent with BPH because it's very well, it's circular, it's very well demarcated. It's demarcated with this kind of hypo-intense rim, which is also a characteristic of BPH. And so really nothing too dramatic appearing anywhere else in the transition zone on this T2. But if you scroll through on your DWI, you appreciate that there appears to be a hyperintensity here on the DWI. And then when you go and look at the ADC, you find, oh, there's a hypointensity there on the ADC. And this was biopsy. This was actually found to be 4+3 prostate cancer. But again, just looking at your T2, very difficult to evaluate the transition zone sometimes because of these BPH-related changes. But when you scroll through on DWI, you'll see a hyperintensity. When you scroll through on ADC, you'll see that hypointensity. Another example here. So this is a patient who had relatively substantial BPH. This is towards the base of the prostate gland. This is our T2 image here. You can see we're seeing the bladder, so we're near the base of the prostate gland. And he actually had a relatively, this was, if you follow this up and if we were to look on sagittal, this is actually sort of a lateral, this is a lateral lobe that kind of grew up and was intravesical. And you can see here on T2 images This area of his lateral lobe has just kind of this sort of charcoal gray, smudgy appearance to it. And when you look, sorry, I've sort of switched the image, the typical sequence that I've been putting these in. So this is our T2. If you look, here's the DWI, and it's DWI because this area is hyperintense. So there's a hyperintensity on DWI and a corresponding hypointensity on the ADC. And so this tumor was biopsied, found to be a Gleason 4+3. This was a PIRADS 5 lesion. Again, we're not going to talk too much about why it's a PIRADS 5 versus a 4 versus a 3, but certainly a relatively large lesion here that is in the transition zone, kind of intermingled amongst the BPH, that can be a little bit difficult, a little bit subtle to see on the T2, and that's why these DWI and ADC images are just so critical. So again, we will go back to some of these common findings that are not cancer. So BPH nodules, as you can see here on the T2 images, they're very well circumscribed. They often have this hypointense rim to them. They can have some heterogeneity internally, but they're in the expected location of a BPH nodule in the transition zone. And typically, they will not have the correlative findings on the DWI or ADC images. So if you look at this under DWI and ADC, you won't see the typical brightness on DWI or the typical darkness on ADC that you would for a prostate cancer. And again, we went through a little bit of that central zone finding. That can also be tricky. Again, it's in the midline. It usually surrounds the ejaculatory ducts, and which you can see on MRI. So if you see an area of hypointensity kind of surrounding the ejaculatory ducts in the midline that appears reasonably symmetrical, you should be suspicious that it is not prostate cancer, but it may just be typical central zone findings. And as you can see here, we look on DWI. We don't really see a lot of strong signal. There may be a little bit of subtlety back here on the DWI, but nothing really dramatic. And on the ADC, again, we don't really see anything here dramatic on the ADC. So again, this is just normal central zone findings. And here's another example of that. This is the whole, so you can see here actually a good look at the central zone. So the peripheral zone is here. That's the outermost zone. Then in between the transition zone and the peripheral zone is the central zone here. And you'll see here it's very symmetrically dark here, right? It's like this perfect kind of ring shape that's wrapping around. It's pretty much dark all throughout. This little white spot here, that's one of the ejaculatory ducts. So that's one way to identify that you're looking at the central zone. And again here, we don't see that hyperintense signal on DWI, and we see a little bit of kind of mottled hypointensity here on ADC, but because of the anatomic location of this, the symmetrical nature of this, the real lack of signal on DWI and not a strong signal on ADC, you know that this is just central zone. It's a normal finding, and it's not prostate cancer. And again, we went through prostatitis earlier, linear wedge-shaped findings in the peripheral zone, not well delineated, and there won't be a correlate on DWI or ADC. So that's the end of the talk. What are our conclusions? Well, first of all, interpretation of prostate MRI requires familiarity with the key sequences, and it requires practice looking at these images. Multiple sequences are really required to fully evaluate the prostate gland. So you can't just look at the T2, you can't just look at the ADC and DWI or the contrast enhanced images. You need all of these images to fully evaluate the prostate gland. The T2 images provide good anatomic delineation, and at UCLA, these sequences are called T2 320 is at the end, or the other one is T2 with this axial oblique prostate. So those are the best sequences to look at when you're trying to get anatomic delineation of the prostate. And on T2, cancers are hypo-intense or dark. They're poorly circumscribed. They're smudgy in appearance. And on T2 sequences, you can typically identify peripheral zone cancers with T2 sequence imaging. The DWI and ADC sequences have poor anatomic delineation, but they are very, very good for identification of cancer, and that's particularly in the anterior zones of the prostate, where BPH nodules and anterior fibromuscular stroma and the urethra can make the prostate look heterogeneous. Those are the sequences that are critical for looking at those areas of the prostate. DWI cancer is hyperintense on DWI, and again, you're looking for the sequence that has this BVAL nomenclature at the end of it, this very long name with BVAL at the end of it. ADC cancers are hypointense, so you will not, so they're dark, and they end, the end of the name of the sequence has ADC in it, both of those sequences are also required to confirm areas of suspicion in the peripheral zone. So if you see something dark on T2 in the peripheral zone and you're suspicious, you then need to find a hyperintense correlative lesion on DWI as well as a hypointense correlative lesion on ADC in order to confirm your suspicions that that is a prostate cancer. So I would encourage you all to look at these MRIs. Don't just look at the report. Get a real sense for them. Practice looking at them. The more you look at, the more easier it becomes to identify these cancers. And then hopefully in some subsequent lectures, we'll talk about PIRADS, grading, and also talk a little bit about margins, margin status, and staging. Thanks very much.